Good morning, everybody, and welcome to today's webinar on improving care delivery to patients with complex needs. We are going to get started in about 1 minute's time. We have nearly 100 people registered for today, so there's a lot of people to arrive. So probably for the next minute, you've got time to grab yourself a refreshment, maybe stretch your arms and legs if you're physically able, and get comfortable and ready, because we have a great webinar installed for you, and we'll get started in really less than a minute. We'll just wait for a large number of people to get comfortable and start falling into the room. So we'll just give you a moment and we'll officially get started in a couple of seconds. Okay, looks like everybody's getting ready. So let's get started officially. Good morning, everybody, and welcome to today's webinar. The title is Improving Care Delivery to Patients with Complex Care Needs. This webinar is brought to you really primarily by KCE and Aalto University. And I'm George Valiotis. I'm the Executive Director at the European Health Management Association. And it's our pleasure to be supporting them in communicating this really important research and great work that they've done. So let's get started and have a look at the agenda for today. It's a 75-minute webinar, and we've got, I'll hand over to you shortly to Professor Axel Kanye, who will be facilitating the day. And then we've got two fantastic speakers that he'll introduce to you shortly. There'll be also time for discussion and Q&A. So make sure you pay attention and save your questions, which you can put either into the Q&A box, and they might be able to ask them live later in the session. To make sure that today's session runs smoothly, I'll just run through some of the housekeeping. So we're going to mute everyone's microphones, of course. As I mentioned, please make use of the Q&A. This is a great chance for you to connect to these great speakers and get your questions answered. So make the best use of that time. We're going to record the webinar, and we'll make the webinar and the slides available online. So that'll all be there ready for you within the next couple of days. So that's the housekeeping. I do want to tell you a little bit about the European Health Management Association and why we're supporting this. For us, we have a vision of excellence in health management for a healthy Europe. And our mission is to support the spread of knowledge on effective health management, which is exactly like why we support webinars like this to happen today. And hopefully you'll experience that through our values of excellence, quality, inclusiveness, relevance, and respect. And I trust you'll feel that through how this webinar is delivered. Uniquely, EMA is the only membership organisation in Europe to bring together the full health management ecosystem. We're a recognised and respected amplifier of best practices in the evolution of health management, which I hope you'll see today in this webinar as one example. And similarly, we provide an environment where evidence, challenge, and experience are valued, and complex debates on current topics can take place. So maybe you'll have a complex debate today, and we hope you have really great discussions and learn more about improving care delivery for patients with complex care needs. So that's a bit about EMA. What I'll do now is hand you over to Professor Axel Kanye. He also happens to be the EMA Vice President. Axel, great to have you joining us today.
Thank you so much, George, and thanks very much for the kind introduction. We're absolutely delighted to be here, of course, and I'm delighted to be able to introduce two very eminent members of the scientific community. That is Nadia Inamid, and she will be presenting something on a very significant report that has just been produced for the Belgian government on integrated care. And Nadia is one of the health service research experts at the Belgian Healthcare Knowledge Center in Belgium. And we also have with us here, and I'm delighted to say that, Professor Paul Lillerank. Paul is, of course, a professor for quality and service management at Aalto University, and he has published very extensively on issues around logics of healthcare and other health management issues. And we are delighted to have both of you here. I will be in the background and kind of monitoring your questions as well, and because we will come to the question and answer session later on. But without further ado, I will open this floor now to our first speaker. We will have Nadia first of all, and then we'll move on to Paul in the second part of it, and at the end of it there will be a question and answer part of the webinar as well. So you can, at the moment, you can already put your questions into the Q&A, into the chat room, and we will actually then transfer that, and I will ask these questions in the later part of the webinar. So delighted to see you all, and I will give the floor to Nadia first. So Nadia, the floor is yours.
Hello, everybody. Today I will present you a little part of a big report about integrated care in Belgium. And the title of the presentation of today is Designing Integrated Care Policy, Which Data Are Needed? Oops, sorry, I have got a little problem with my mouse. Okay, can't. Sorry. Oops, sorry. Blah, blah, blah. Sorry for that. Oops. I don't know what you are seeing now. Probably the presentations.
We can see your notes at the moment, the presentation and the notes. So
okay. Now it's better. Yeah.
We're still seeing. Yeah, now it's better. Yeah, absolutely. Thank you.
So sorry for that. The project was commissioned by the Ministry of Public Health, and it was carried out by KCE as the Knowledge Center for Health in Belgium, and we will support it by the Catholic University of Louvain, and from PAX. It is an institution for quality of care. Shiften is a thinking design company, and 2 companies specialized in survey. First of all, what is the context of integrated care in Belgium? Integrated care in Belgium started in 2008 with the chronic patients, and several plans stem from this first initiative to lead to 12 projects on integrated care. The duration of this project is end last year. In parallel, there are some reform in Belgium. The 2 main reforms are the organization of hospitals. They were characterized before by competition between institutions, and now there are organization in network with structural organizations in which each member of a network specialize their activities. Primary care are also now organized in network, and it started in Flanders. And after all this reform, all these plans and pilot projects, the Ministry of Health will have the intention to assess the maturity of integrated care in Belgium, and it was the purpose of our report. Firstly, the professional assess the maturity of integrated care with a validated tool called Sirocco. Sirocco is organized in 12 dimensions, and you see on the screen the result of this evaluation presented as spider diagrams. Each dot are proportional to the number of respondents. So dimension was big dot, meaning that there are a big agreement between participants on the assessments. In contrast, dimension was a lot of little dots represent a more scattered opinions between the professionals. As you say, the maturity is assessed low for every dimensions because the median assessment is 1, except for 3 dimension. It is population approach, process coordinations, and evaluation methods, where the median score is 2. It's not very high, but it's better. When we go to the patient now, we ask patient to assess their experience of the chronic care model using the PASHIC instrument. The PASHIC instrument includes 20 questions related to 20 dimensions organized in 5 supra-dimensions. All the dimensions again are scored very low in Belgium, except 2 dimensions. The satisfactions of care. Patients say that they are always or most of the time satisfied of the care in 61% of the cases. It is very strange because they don't experience the chronic care model, but they seems to be satisfied of the care they received. Another good point is the fact that the caregivers take into account the value of the patient once they propose a treatment, and it is the case in 58%. How we do to design recommendation for policy for more integrated care. Based on the Sirocco evaluation, we organized 16 discussion groups in 140 professionals. And the result of this discussion is that we get more than 500 action points clusters in 11 groups. It is a very huge amount of action points. So we decide to discuss the clusters with experts, with 82 experts in 8 word cafe, to know what we have to do with all these inputs, and they propose to starting with a phased approach and starting with the action point. There are prerequisites to go further for integrated care. Based on this input of the discussion groups and the word cafe, we draft 11 recommendations. The recommendations targeted the organization, the funding, but also the research and the training of the health professionals and social professionals. To implement this recommendation, it is very important to have to analyze and to interpret data. It is a prerequisite to implement our recommendations. Therefore, it's why the question arose of the data needs. Why data is so crucial to develop integrated care policy? It's because integrated care needs population management, and population management lead to defined geographical territory as a unit of integration. At micro level, it's the point of care of the patients. Meso level, it's the level of organizations such as hospital network, and macro level, it's the level of the decision making. As in many countries, Belgium has several governance levels, so territory governance level for health, and so territory must be adapted also with this constraints. Based on the territory, we can define the needs of social and health care for the population in each territory, and afterward adapt the supply accordingly. And what data is available in Belgium? As we will see, there is a lot of data sources for defining the care supply, the care consumptions, but also the social care. To define the supply care, we have a lot of database defining the healthcare providers, and it's mainly managed by the federal entities, and defining the healthcare institutions, but in this case, it's mainly managed by the federated entities. We also have data on care consumptions. So in Belgium, the healthcare insurance is mandatory, and it's managed by sickness funds. Patients, healthcare professionals, and hospitals send data for billing purpose to sickness funds. Sickness funds gather all the data and send it to IMA. IMA is an organization that gathers all sickness funds and manage the data for research purposes. Sickness Fund send also data to Receive INAMI. It's the institutions that manage the health insurance. And hospitals send also data for, to the Ministry of Health, also for budget purposes. Healthcare professionals and hospitals send also data to Cienzano. Cienzano, it's the institutions of public health that gather data to monitor infection disease, physical and chemical risk, but also gather data for epidemiology of disease. So they have a lot of work this last years, and also for quality of care issue. Hospitals sent also data to a lot of registry, such as the Belgian Cancer Registry for the cancer patients, eBirths to manage the epidemiology of perinatal epidemiology, and also for budgets issue the RHMSMZG. It is an administrative databases gathering administrative, nursing, and medical data. So the flow of data are very big in Belgium. And Belgium also characteristic is that social data are not linked with healthcare data unless in the social security database that give to target groups preferential reimbursements for their care, and it's for disabled people, people with low income, and people with very high health expenditures. These three groups can have a preferential reimbursement plan. What are the challenges to create a real data ecosystem to tackle the need of information to organize integrated care? The data must be fair. It means that the data must be findable, accessible, and interoperable and reusable. But we have also to take into account the LGPD and the prerequisite in the developing space in Europe, the European Health Data Space for People and Science. However, we have said that in Belgium there are multiple data sources, the Sickness Fund, the social institution, the administration, and so on. You have seen that data are mainly collected for billing purpose and in a lesser extent for patient treatment and legal obligations. Based on this, it's very difficult to make epidemiological conclusion to organize the care based on this kind of data. Such it's important to link this data with the patient records. But the patient records are in multiple languages in Belgium. We have French, Dutch, and German. And based on several standards as the International Classification of Disease or International Classification of Disease for Oncology and so on. So the federal government take the initiative to create the Belgium Integrated Care Health Record. It's not yet set up, it's in development, and it is a collaborative environment that follows 7 objectives, but the last objective is the population health management. So we know that in future that it will be easier to integrate care and organize the care. So what can we take home with all this presentation? It's that policy on integrated care focus on a large number of topics. It's focused on organization, funding, research, but also training of the professionals. Data are needed for what? But for the population management, that is the core characteristic of integration of care. And it is needed to define geographical territories in which we can define the need of the patients and the supplies needed to answer these needs. Data must be fair, but there is a lot of obstacle to tackle as the data source, the multiple data sourcing, multiple language and standard. So implementation of integrated care need integrated data. More information on this report can be found in the CASI website. If additional questions after the webinar, you can contact me by email. Thank you.
Fantastic. Thank you so much, Nadia. Really fascinating, especially, and as I said in the chat as well, this relationship between population health management and integrated care, something maybe not everybody in integrated care research community is sort of switched on yet. You know, we will come to the questions at the very end of this, at the very end after Paul's presentation. But just a clarification, Nadia, just a brief clarification at this point. I understand EMA is the repository for all the data in the country, but in fact you have a federal structure, isn't it? So the regions pull the data back down, and can you just say one sentence around the responsibility, who is actually responsible for creating integrated care solutions or the new data infrastructure? Is it the regions or is it the central government? Maybe just a clarification around that.
So it's complicated and better, but it depends on what we have to do. So the sickness funds are organized very locally, and afterward they are organized in federations, and afterwards in sickness funds, and the sickness funds are afterwards gathered together at the national level to make data for research purpose only. But the same data are owned by the INAMI-RESIF, the institutes for the mandatory health insurance, and they give data for the federal and the federated entities.
Fantastic. That makes sense. Thank you so much, Nadia. And we want to hear from you, the audience who are out there, you know, of course. So if you have questions, if you have any ideas and suggestions, and also any food for thought on this fascinating topic of Belgium integrated care and health population health management, do use the chat function. It would be great to hear from you. It's going to be we're going to collect these questions, and later on we come to that and place them and present them to Nadia and Paul, of course. So thanks very much for now, and Nadia, we'll come back to you. Thank you very much for your presentation. And now I'm very delighted to come to Paul, Professor Paul Lillerank, who has been engaged with his team on a significant study that has been going on for a couple of years, I think, and is dovetailing nicely with what Nadia just told us about the data infrastructure in Belgium. But this time we're going to Finland, and we will hear hopefully from you a bit more about a virtual care operator, something that is presumably on the ground, a solution to on the ground designing integrated care for patients and for staff. And before I hand over to you, just briefly, I will put in the chat a link to a paper Paul and his team have also just published in the Journal for Integrated Care. You would want me to say that since I added this journal, so I need to make a bit of promotion about this as well. And then you can just click on the link and you can see his paper as well, and the paper from his team. So Paul, the floor is yours.
Thank you. Are we online?
Yes.
All right. Thank you so much for this opportunity. I'm going to present some findings and insights from a project called Personalized Care with Mass Production Efficiency, or MASSE. We did this together with Helsinki University Medical School and a consortium of medtech companies and service providers, and this was funded by Business Finland. Here in this project, we talk about integration. But we focus on integration at the patient level, and think that Integration happens when a patient gets an integrated care plan that is then implemented in a coordinated way. The mass production efficiency here indicates that we are looking for a solution, or the design principles for a solution that could also be affordable. So we started with the most difficult question related to integration, namely multimorbid patients, patients with several medical issues that are interacting. These kind of patients are often treated in a health service production system that is highly specialized and turns into being multi-provider service system. So you have multimorbid patients in multi-provider service systems. That creates a very difficult situation for integration. And when it's not happening, then patient journey disruptions happen. Patient journey disruptions are those things that needs to be avoided and prevented from the care of multimorbid patients. So for this integration to happen, analytically speaking, somebody must take care of a patient's whole situation. And this must happen at the same time as all the specialized and expensive resources are fully used. So we come to think about taking care as an organizational functionality that tends to weaken or disappear altogether in specialized multi-provider service system. But this term taking care is a little bit awkward, but in the Finnish language we have a very good word for it, huolenpito, which would could define it as the combination of these three things, that I'm taking care of you, I'm looking after you, and I'm worried about you. So this is what, metaphorically speaking, guardian angels are doing. They understand the situation, know what to do or know what to ask, and then tell the doers without being personally involved in doing things. So the question becomes, could we somehow create a virtual guardian angel for these complex multiple provider service systems? Now, this functionality can essentially be done in two ways. We have the old classical, good, traditional way, which would be the patient, him or herself, or the family or a family doctor. If situation becomes complicated, then a personal case manager. So this would be done then manually. So the case manager instructs each of the service providers associated with the patient journey and tell them what to do. On the other end, we have the idea of the virtual care operator. That would be an IT system that would generate for each of these service providers the information that tells them what to do. And if that's not clear, tell them what to ask or whom to talk to. And also provide the same information to the patient and possibly family. So this is the idea. Then what would it look like? This is a mock-up that we developed together with a specialist in geriatrics. That could be the patient card of an elderly person. So this would be a sort of display that you can bring up on a computer or mobile device. There will be, of course, the basic patient information, then the care plan, a timeline, objectives of care, and then various apps or windows about specific diagnosis and the care process connecting to those. And then, of course, the patient reported measures could be taken in, or you could attach then various sensor based data onto this. So this would be the patient card that is designed for each person individually, but it's designed from standard modules in the same way as when you get a new mobile phone, you have to configure it for yourself by downloading apps and then configuring them for your own purposes. So how can this be accomplished? Well, we are not in the business of trying to make a new electronic patient record, because there are already plenty of those. In Finland, as in many other developed countries, there are a lot of data sources and patient records and national archives from where patient data can be pulled. And they need to go first to an interoperable platform where data from various sources and formats is then harmonized. This has already been done, technically speaking. Then from that then follows an intelligence layer, which would be the patient card and the construction tools. I mean, the tools that used to then download the apps and put pull up the patient data and sort it and select it and format it for the card for its single patient. So then there would be a sort of master card that typically then a primary care doctor would have access to. But then all these people along the patient journey who participated, everybody does not need to know everything, becomes too clumsy. So there would be the possibility to tailor-made patient cards specifically for specific situations and users. Like say, if this patient goes to physiotherapy, then the physiotherapist would have a patient card showing those things that the physiotherapist need to know. So this is the technical layout of the thing. And this is a picture showing the same from the side. So you have the source system and various input devices going to an interoperable platform, and then having there an intelligence layer that then creates the patient card and all its variants. Now, as I said, the patient card can be used to download various kind of health applications, and this opens up the possibility of the patient card and the virtual care operator turning into a platform where we could have an app store, so store for digital health applications that the doctor who then tailor-makes the card for patient can then pull up app, let's say app that helps to manage Parkinson's disease or diabetes, or some self-reporting app or communication app, or connect a sensor that follows cardiac rhythm and so on. Then the service card then denotes when there are physical service providers, like say physiotherapists, so their services could be formatted into a service card and then connected to the patient card. So this takes then for the VCO back office with all the IT construction tools, and then the front office where the services would be then provided with the help of the virtual care operator's patient card. Then this is the last slide. Now this is as far as we came in thinking about the design principles. The next step is to build a prototype and test it in a real-world context. So we are talking now to a number of companies and players in order to put on a consortium, but there are certain known unknowns, research problems that we need to deal with. The first is the patient card design. Let's focus on the question of who needs to know what. Then we have the research problem related to what happens to service production when people now, with the help of the patient card, people know what to do. Then what do they really do when they know what to do? And then finally, there's the question of economic sustainability. What kind of business model would there be needed for a virtual care operator? Who would pay for it, and how would it prove its worth? So this is future research, and if you are interested, so please get in touch. The sort of situation is still quite open for how to form the consortium and go take it from here. So thank you very much for listening.
Fantastic. Thank you so much, Paul. That's really fascinating because it kind of like dovetails with really what Nadia said early on about the situation in Belgium. But just to highlight, I think the uniqueness of your project, Paul, I think is really around getting design principles on the ground first and kind of like think about the solution from there on, as it were. And that's really fascinating and unique. Just a clarification, because before we move to the next section, as it were, I just wanted to ask you, Paul, do you anticipate, you're obviously in a different position in Finland with the data, with Kanta and the data infrastructure that exists there, but do you anticipate the social care data to be in there as well? And I know you have disappeared now from my screen, but I know you're there somewhere and your team is there. And oh, there you are.
Yeah.
There we are.
Our camera tends to go crazy. The big issue in Finland is about integrating the healthcare and the social care, as you know, and there's a massive top government level reforms in that respect. That I think will be possible at some point, but not in the near future. I'm just having an integration about the health related information, because there are private players and there are various districts that have their own system, so it's complicated enough. But yeah, I think in the future we'll move towards a total integration of both health and social care data.
Fantastic. I like that optimism, Paul. That's great. That social care data has been a huge barrier. Integrating that and involving that has been a huge barrier in England and Wales, Scotland, and Northern Ireland for us, at least here in the UK. Great, fantastic. Well, thanks very much. We'll move to some of the question. The question and answer chat has already been filling up with questions. But I come to you, Nadia, first of all, just briefly. We would like to know a bit what the next steps are. This has been a significant project and a huge a report for the government in Belgium, and presumably you want to see some development now on the policy side. Is that right?
Yes, it is. The National Institute for Health Insurance is now developing, based on our results, a new plan for integrated care, and they started now and they will finish next years for more integration of care. And it's all in the first step is care, and social care will be later, because we have the same problem in Finland. It is very complicated to merge those data and those care also.
Yeah. And just to follow this up, the interesting side and aspect of your project is, of course, that within the Belgian health system, if I understand it correctly, the role of the sickness funds or insurers, it's really about sorting out the payment to the care providers, isn't it? I mean, that is one of the difficulties.
The main role is to pay the care provider, and they have a role of research, and they give advice to the government of the federated and the federal government and the federated entities to develop some care or some organizations, but their role is more at that level.
Yeah.
But it's the only role of the sickness fund. Organize the payments.
Yeah, good. Okay. And then I come to Paul. Paul, this has been obviously, I had a privilege of sort of like observing your project in the last year a bit. So it's been really, really fascinating. I wonder where you see this going next, as it were. I mean, some of the technological challenges, these sort of like the funding challenges maybe as well, and the partnership and consortium challenges. Do you want to maybe add something, a couple of sentences around that? Because it's been quite fascinating how to do the next step after this design. These design principles have pointed you in the right direction, isn't it?
Yeah, well, we have been discussing with a number of IT companies. I mean, obviously, we need somebody who can do programming. And they are all telling us that this is doable, technically speaking. I mean, this is not rocket science. There's no breakthrough science required. This patient card system can be built from existing components, but it still needs to be built, and that costs money. So we were discussing with several companies, and don't know exactly right now what kind of configuration there might be, but I would say that several companies are interested. Then that would also require then a test site, test bed, or living lab, if you wish. And we have been talking with several of the Finnish health and welfare regions, and many of them are interested in contributing a test place. So the IT companies first build a prototype of this thing, and then we install it in a site, probably first for a specific patient group, perhaps something narrow like Parkinson's or MS or something like that, and then just keep experimenting with it, and then have research going on, trying to find answers to these 3 research questions that I mentioned, and the design of the patient card, who needs to know what, then what happens to the service processes, and then there's the economic sustainability of this whole system.
Yeah.
So I'm hopeful that we can get this kind of consortium up and running in the near future.
Yeah, and when you say design of the patient card, that sounds simple and they get it up and running, but actually behind that is a real huge complexity, isn't it? It's about, if I understand it correctly, I think from your presentation, the issue really is to know what to do, as it were, when you with the patient. And that's sort of like really is a mixture of competencies, skills of the staff, but also of the right information. And this is, I think, where your design principles are coming together, isn't it?
Right. And this is perhaps where some breakthrough technology might be needed, because if you think of a multimorbid patient, the patient record is a kilometer long. And not everything there is relevant for the current situation, but something might be relevant for a different current situation. So what is the data that needs to be there on one screen, one A4 kind of piece of real estate, where to put that there? So that's a major question. We have been talking with a number of primary care doctors, and they've been very excited about this kind of possibility. But as it happens, they tend to have very different views of what they need to see. So then one option would be to, if you have the primary care doctor designing the original patient card, they can also design or give, let's say, a piece of artificial intelligence, the rules that I want to see everything that relates to this and this and this. Please find it for me from these patients' data. So that is possible, but that would take a little bit of innovative thinking, I'm sure.
Yeah, and it's fascinating that there are really strong parallels with the challenges that Nadia's team has actually been approaching and been addressing, and that is population health management. We do have the data. The interesting thing is we're drowning in the data. It's actually too much. And the question is, how do you sequence it? How do you actually, in population health management, how do you segment it? How do you segregate it? And then of course, risk assess it. And the risk assessment, I think, is part of Nadia's project, but or sort of integrated, how to design integrated care in Belgium, but it's also of your project, Paul, because it's really about risk, isn't it? When a staff member sort of encounters a patient, it's about assessing the risk of what happens next, isn't it? Right.
But this, our thinking has been deliberately focused on the individual patient level, not population level. I understand population level is important, but this is not the primary objective of these things. I mean, then you have to talk about prevention on the individual patient level. But then quite obviously, if this kind of virtual care operator is up and running, and the patient card is there, and it generates a lot of data. And that data can be used then, I believe, on a population management to help plan various sort of local strategies for health promotion, or which people should be called in for consultations and so on and so forth. So I mean, because this thing is so complicated, so early on in the master project, we made a couple of decisions to focus on certain things, not to get overwhelmed by the complexity. And one thing was have this strict patient focus. Another one, as it sounds, we ignore all the lawyers. Because, you know, the major risk here is that the government lawyer comes and say that, fine, this is a good idea, but you can't do it. You are not allowed to do it because of the data security, whatever. So we are very much aware of that. But I mean, if you start thinking about integrated care from the legal data security perspective, you are not going to get anywhere. So we think first design a solution, then demonstrate that this is efficient and effective, and it can save the government a lot of money. Then if we happen to run into a data security legal issue, then so be it. Then we make it political.
Yeah, absolutely. Yeah, that's really interesting, and that's something that's been resonating with our audience who've been asking questions around this. And I come to the audience now. I mean, we have a couple of. First of all, before I say that, you said a test bed for Finland. I can assure you, Paul, your project will also be test bed for Europe and for other countries, because no other country has actually cracked that really. I mean, that's sort of like a patient-facing up, you know, and feeding that with the data. So it will be very fascinating for everybody to see. But I come to Nadia now, and before I ask you, Nadia, I just wanted to say there are a couple of questions in the chat, but one of the interesting one also comes from Lucia Ferrara. Lucia, if you don't mind, maybe you can also unmute yourself and maybe we can get you in. But before I do that, Lucia, I'm going to ask a question from Anna-Marie Jutinen. She says, thank you very much for the great presentation, Nadia. The question really is, how do you measure the outcome? How do you how can the outcomes of integrated care be measured in Belgium? Have you thought about what the next step after the next is, as it were, not the implementation, but then how do we say, how do we know we're successful? How do we know it works? Is there some work going on?
Yes, it is. A lot of universities are working in Belgium on integrated care, but there is a lot of instruments, but the government have chosen Sirocco, so we can redo Sirocco several times to see if the dimensions are better than what it is now. And I'm thinking about what Paul has just said, and I say a lot of parallel with Belgium. And in Belgium, the patient card, if I can say it, it's not so good developed as in comparison of what Paul has said, but we have the eHealth viewer, and the eHealth viewer, it's a platform. It's the only platform where the data of the patient are not anonymized. And in the eHealth viewer, only if the patient give his informed consent, but if the patient give the informed consent, all the professional can see all information about the patients, and the patient can see his lab tests, the result of imaging, and so on. But the big problem, it's a problem that Paul highlighted. There is too much information, no structures in the presentation of the information. So it's sometimes useless because the professionals are deep in the mass of data and they don't know what is important for my relation with the patients and for my task. And so I see a lot of links between Belgium and Finland.
Yeah, and that relevance, that question of relevance is important, isn't it? For what are the data that are relevant for these particular issues? I come to Lucia. Lucia, if you happen to be in the audience still, do let us know and unmute your phone. Maybe you can ask a question because it actually resonates with both Paul's and Nadia's presentation.
Thank you, Axel. Thank you, Nadia and Paul. Can you hear me?
I think you just cut out, but you are hopefully back any second. We can't hear you at the moment.
Can you hear me?
Yes, we can hear you now. Sorry.
Okay.
Go ahead.
Thank you, Axel, and also thank you, Nadia and Paul, for the interesting presentation. I'm Lucia Ferrara from Bocconi University in Italy. And I had one question for you, because it's really interesting the amount of data that you have. And also in Italy, we have a lot of data and several experiences of population health management. But many of these experiences at the regional and national level are currently on hold because of the Italian Data Protection Authority that is hindering data linkage at the patient level because of privacy issue. I know I'm following also project in Belgium, and I know that there are a lot of data that you are able to link at the patient level, also between different settings and hospitals. So my question is, how do you have an idea? Maybe the question relates with both of you, so Belgium and Finland, on how your system is facing the problem of patient privacy and data linkage at the patient level. So how they are solving this huge problem. And thank you for this.
Fantastic. Thank you, Lucia. Let's come to Nadia first and then to Paul, if that's okay.
So the data are mainly anonymized and given to the research agency based on aggregated data. This way we use the pseudo anonymizations. This way we are sure that we can't find back the person who is characterized, and especially when we group the data, and we have a rule that we can give information on a group of patients with less than 3 occurrences. So this way we can't know who is the patient behind the data. And there is an organization in Belgium that is specialized to anonymize this kind of data. So it's how we can manage all the requirements of RGPD, and it's more and more complicated, but we try to do the best to have data and privacy. The equilibrium is very difficult. The balance is very complicated, but we need data, but we understand the problem of privacy.
Yeah, and Paul, I come to you.
Yeah, the virtual care operator would deal with patient level data, not aggregated data, patient by patient. And then, of course, the question is, can data from different databases be connected, which is an issue. But I believe in the end, this is a matter of consent, or getting the consent of a patient or the family, or both, for using data for certain specific purposes. There are some projects on the way in Finland, I said, to develop this sort of consent management systems. So I hope that will sort of solve the issue. That perhaps, I mean, a doctor can see everything because that's needed for the clinical work. But then, if some of that data is shared to some other service providers, then that might be an issue.
Absolutely, absolutely. That's really interesting. Thanks, Paul. And now to wrap this up, I know Arthur has his hand up. Arthur Schroeder has his hand up. To wrap this up on the data side and GDPR, before we move on to some of the really fascinating questions that come in the chat as well, on more content issues, as it were. Arthur, do you want to just briefly articulate your question around the consent and the informed consent for patients as well?
Yes, you hear me? Thank you for the inputs and the presentations. We are developing a Health 4.0, and just the issues what you all mentioned, we are all have a lot of our technical solved, And we now are going to do an operational part in one of the hospitals in the Netherlands, in Isala, to make it in complicated care. One of the points is that we bring the data by the person, and the person is the central data, not the institution. And then you can visualize another way of doing business, because you going to personalized medicine. And the one constant in the process is your whole life you collect data, what is content and the consent around it, but also the environment where you're living in, who are all interacting with the data. The most of the data where you're talking about is more administration data, but not the raw data what you collect from the systems who more and more personalized. Even the data collection in your home are becoming more validated than some in the laboratoriums. So there is a mind shift needed, and we do that in Health 4.0. You see that also in the Pharma 4.0, the EMA is collected that you have to other way to organize your data. And that is what we're trying to do. We do that in a personal genetic locker. And when we build on a DNA, your biomedical passport. And that is another approach, because you collect from your birth all data. And what's very important is to keep you to make really preventive care on the person. But you had to make a starting point. That's what we do, and we do it now in colon cancer and that kind of traject with medical universities in the Netherlands to make an infrastructure to exchange the data on fair principles. We are a partner in GoFair, and to make it possible to keep data mobility, because everything is local, but people are not staying local because mobility is a big issue also in Europe. So we built a European framework on European software, on European database organizations, and the databases are by the person. So you can more personalized environment. That's what we do to make it possible when you go from Europe to England, that you have no issues, because data issues is very important.
That's fascinating. Yeah,
what also important is when you exchange that also in other languages. That's another thing. So you had to make a European mind, not from.
And that's something that's probably being addressed in Belgium and Finland, because both countries, in fact, have several languages, if I understand it correctly.
So, yes, it is.
But if you want to know more about it, that's the point. We can give workshops. We got a lot of consortium. For Paul, is it interesting maybe to connect to see what is doing, what we're worldwide doing, because the data is not on the border anymore. That's the problem. You had to think another way of thinking. That's
really fascinating point about mobility, Arthur. That's really helpful. I come to Nadia first and then to Paul probably as well, because clearly, Arthur, as you said, this has relevance for the Finnish project as well.
Yeah, surely the mind shift to the data owner, it's starting also in Belgium, and it's why we have started with the eHealth viewer. But the eHealth viewer is a competence federated entity, so we have 3 different eHealth viewer, but the eHealth viewer can be communicated with each other, and it's like in Europe, different country, it's different region in Belgium, but it works and it's possible. But the problem of language remain, and the file of the French-speaking people are in French, and the Dutch people speaking are in Dutch. So for some caregivers, it's probably difficult to access to all data. Because it's not structures and it can be in another language. So there is some parameters that use international classifications, and when it's well done, it's not always the case, but when it's well recorded, they can find a way back. But yes, that can be a problem. And for go to another state, it's not in English also, so it can be complicated. And it's now not accessible. The eHealth viewer is not accessible from other European countries. It's only accessible from Belgium.
That's interesting, Nadia. Thank you so much. And Paul, any ideas and any thoughts on the mobility issues, really?
Yeah, we are aware of that there are differences in different countries, and perhaps Finland is a little special because we have this Kanta, so national archive, where all the health data goes and where it can be pulled out, even though it's not very useful, but it's there. So I understand that in a, say, Central European or American or Japanese environment where there's sort of hospital groups tend to own the data, then the situation would be different, and then there would be a need for the discussion about the mobility of the data. Who owns the data?
Yeah.
Is it the patient or is the caregiver? But I want to add here that I believe the virtual care operator can take many shapes and forms, and that's why we call it virtual. It's not sort of, the idea is not tied up to a specific organizational configuration. So they could be, say, could think of an American style health management organization or a private care provider that would build their own virtual care operator for their own purpose. So it would not necessarily be a sort of comprehensive solution for a whole region. Or you could have a virtual care operator that is dealing only with cardiac patients, for example. So I think the core idea here is to use information technology to recreate the guardian angels taking care functionality by providing service providers the information that they need so that they know what to do in each particular situation. This is the core. Then how it's done depends on the environment and what kind of technologies you want to use and what kind of service systems there are. So virtual means really virtual, that it can take many forms.
Yeah. And the issue of data and doesn't let us go, really. I mean, this is of course at the core of the challenges. And Anna-Marie Jutinen also placed a question in the chat about this, and she said this in relation, of course, to Finland, but it's the same for Belgium. She's saying, well, you have the Kanta archive. But is it actually possible to use that Kanta archive as an interactive patients and professionals platform, or as it were to archive actions, etc.? So not as a reactive one, where you just draw down the data, but in fact, is it actually depositing? Are you depositing actions into this as well? How interactive is it? Because this will be at the core of it. We know from patients and healthcare professionals, they have their medical notes are growing copiously all the time, and it needs to be in real time available for others, isn't it? And that's a significant challenge, isn't it, Paul?
Yes, it is. But a national archive is an archive. Okay. So it's not designed built for interactive, so say production management tasks. It's an archive, but since it exists and it has been there for a while, there are routines of how different electronic patient record systems are by law sort of required to push their data into that archive in certain formats. So that sort of those routines are in place. Then you think of a virtual care operator sort of pulling data about specific patients. So I don't know how it technically will be, that they could be taken from the Kanta, where everything already is, or they could be a route that you take them from let's say the Effica patient record systems in this way, and then from the other Pegasus system this way, and then private providers would provide it that way and this way. So what role the Kanta is going to play in the back office of a virtual care operator is not clear at the moment. But one way to look at it would be that virtual care operator is the operational front office of the Kanta archive. You could think of it that way also.
Yeah, and that's quite reliable, and it's been in place for a while now, so that's really positive. Nadia, I come to you. I want to be sort of like face you with a slightly unfair question, and that is, we are always talking about data that are required for the analysis, population health management, integrated care, etc., and the same in Finland, but also in Belgium, and as if the data are complete, as if they are comprehensive. because you have insurer model in Belgium, a mixed insurer model, of course, and something similar exists in Finland. What we notice now in England is that because of our health system, our public health system is actually overwhelmed. We are seeing private companies mushrooming, providing health services on a private basis for cost, but these data, when patients draw on them, these data are actually lost. They're not in the public health system. They wouldn't be resting with insurers anymore. And just to give you a figure, about 25% of all Generation X individuals and all young people, now in their 20s and 30s, 25% of them don't actually register with the public health system anymore. So they draw their healthcare from private providers, Amazon Medical, apologies, Babylon, others, So is there something similar going on maybe in Belgium, and might that be a significant issue? And then, of course, we come to Paul as well.
No, it isn't, because in Belgium, the health insurance is mandatory and it's covered 99% of the populations. And the rest is mainly migrants of illegal people. And we try to give them a special status. So there is very, very few people that are not covered by the mandatory insurance. And the difference between private and not private medicine in Belgium is very, very thin, because the mandatory, all the procedures are coded with the nomenclatures, and the difference with private and not private is the price that the provider asks, but the reimbursement is the same if private or not. So there are some supplements when you go to private medicines, but it's the only difference is the same for hospitals or for private providers. So we don't have this problem in Belgium, fortunately. We have a lot of problem, but not this one, because it's due to the mandatory aspect of the insurance.
Well, let me just clarify that. That's really good to hear. That's really good to hear, of course. Let me just clarify that it's mandatory as well in in England, but they're just not using the service because the service is overwhelmed. So it's a slightly different problem. But I hear you. That is not a problem in Belgium yet.
No, the supply of services is very large, and so we have a little bit too much doctors, so it's not a problem.
What a fortunate situation. Paul, any thoughts on this issue? That is really
well, in Finland we have the same long-term trend of people getting disappointed with the public services, particularly the long waiting times. So there are a lot of private insurance being bought, particularly for small children. That's been going on for a while, but as I said, also the private providers are required to report the patient data to the Kanta, so there will not be a sort of isolated data silos around the private players.
That's interesting.
And they are consolidating rapidly, so there are basically 3 big players.
Yeah. I got a couple of fascinating questions here. One is from Elena Michele. Elena, this is a question for Paul. If I understand correctly, she says this card would include body weight composition data. She asked, this is a clinical question, it would be a great way to monitor whether the elderly suffer from malnutrition or sarcopenia. Is this possibility included? This goes to the details and the nitty-gritty of that virtual care operator card.
Well, on the patient card, as we envision it, you can download whatever you like, if it's an approved app, and certainly sort of weight control or breathing control or temperature control, whatever control systems can be put there if the designer of the card and the doctor deems that this is necessary and needed. Then yes, sure.
Yeah, fantastic. That's great. And I got to ask, when it comes now to how do we implement this? How do you make these things happen? What are actually the outcomes? What are the findings of both of your projects, really? What are the lessons learned, really? And how do you advise, what would you advise health managers, and how would you involve the health managers to focus on advancing the systems in your countries? So first, maybe I come to Nadia. What are the lessons for health managers on the ground, as it were? I know this has been a high-level report for Belgium so far, but is there anything that health managers can pick up on?
For a health manager in primary care, a first lesson we learned from Flanders, it's the Flanders design to cut the territory in sub-territories. And they see that the sub-territories are too small, because when they have to make arrangements with hospitals, they are too small in comparison with an hospital network, and they don't have the competence for negotiated and for arrangement and to organize pathway and so on, because the hospitals always take the lead because they are network with several hospitals and they have more human resource to do it. So it's important to organize the territory in comparative forces between the players, and the Flanders is thinking about this issue, for example.
Yeah. And Paul, I know this is still in the design phase, but when you're looking forward, health managers, apart from the joy and optimism that they will probably feel when this comes on board online, what do you think are the lessons now at the moment?
Well, while doing this project, we have, of course, run into a number of initiatives and startups and whatever. And my perception is that the whole idea of integrated care for multimorbid patients is out there all over the place. Everybody understands this problem. There are a number of solutions, but we haven't run yet to a solution that would sort of pull all these different technologies together. In that sense, I said it has never been difficult to convince anybody in the health services that a virtual care operator would be a good thing. Never. Everybody says that yes, this is what we need, but then there's not how should we do it, what are the obstacles, blah, 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 and we get into these technicalities, and particularly the organizational change issues of who should be in charge of the patient, should the public primary care health centers, what kind of role would they have to take here, and so on and so forth. But another issue is, of course, that Finland, as well as everybody else, is running out of money. And there will be a dire need for cost-efficient solutions. So we have done a lot of research trying to build up the argumentation how to demonstrate that integrated care is more cost-efficient than disintegrated care. And there's a lot of work that needs to be done that, but you need the sort of the hard numbers on the table. That's what the politicians are going to listen to.
Absolutely. And that answers some of the questions, or response to some of the questions we had in the chat as well. What are the legislation that is required? What's the policy development around the policy power, the authority as well to bring these things to fruition? I mean, this will be a long journey still we're on, I suspect, in both countries. So we're coming to the close of this webinar. Can I just say a big thank you to both of our presenters, Nadia Ben-Ahmed from KCE in Belgium, but also to Professor Paul Lillerank from Aalto University. It's been fascinating presentations and fascinating discussions really with our audience. So thank you very much indeed. I also want to extend a big thank you to EMA, to the EMA team, under George Valiotis, and how they actually facilitated this. And thank you very much to the audience for the wonderful questions. You will be able to get the recording of this webinar, of course, and also the presentations in PDF form if you wanted to. We will be happy to facilitate that. And if you want to stay in touch with either Nadia's team or Paul's team, do let us know. Fire off an email to EMA, and we will be passing that on as software to both of their teams, and then they can continue the conversation. Thank you so much to everybody involved, and I wish you a good day and hopefully a nice rest of the week. Goodbye.
Good.